Psychological stress and wound healing. Our PICO question is, in adult burn victims, what are the effects of psychological stress on wound healing time versus no stress at all? Our population is adult burn victims. Our impairment is psychological stress. Our comparison is stress versus no stress, and our outcome is wound healing time. Our patient case scenario is about a 35-year-old male named Greg who tripped over a pile of sticks while camping with his family, landing on his right side into the campfire. Greg was taken to the ER that night in severe pain with burns along his right torso and right medial arm, proximal to the shoulder, ending just distal to the elbow. Imaging was negative for fractures and was treated for second-degree burns on 10% of his body. Greg works in marketing and is a healthy individual who enjoys cooking, playing with his children, and exercising. He is currently training for a half marathon with friends. He's a non-smoker, he has no comorbidities, and he feels guilt. Second-degree burns are partial thickness, and there are two types, superficial and deep. Superficial usually heals within 2 to 3 weeks with appropriate wound dressing and application, and it usually heals by epithelialization. Deep usually heals within 3 to 4 weeks, and it heals by secondary intention, and you also can experience significant hypertrophic scarring and wound contracture.
Greg has now been attending outpatient physical therapy once a week for wound treatment. It's been 4 weeks, and Greg and his PT are concerned that his wound hasn't been healing. The PT has decided that he's going to treat the wound with silver foam to decrease pain and facilitate healing. Dressings are then changed once every 5 days. So far, there has been no sign of infection, and Greg's pain is at a 6 out of 10 level. We modeled Greg's case after the ICF model. His impairments, activity limitations, and participation limitations are listed below. Impairments, the main impairments listed are a decreased range of motion in the upper extremity, specifically with shoulder flexion and abduction, elbow flexion and extension, and then decreased trunk rotation. Greg also is experiencing decreased sensation in the upper extremity and the trunk, and decreased rib expansion, which is affecting his breathing and lung expansion. Activity limitations are difficulty carrying items such as groceries or picking up his kids, unable to rotate his torso to look around, reduced ability to perform his ADLs, difficulty breathing, difficulty reaching with his right upper extremity, and an inability to perform his usual tasks at work. Participation limitations are difficulty picking up children, unable to play with his kids, unable to train with his friends for their half marathon, difficulty cooking with his wife, unable to participate in carpool with coworkers, and unable to fully participate on the team project with his coworkers.
So continuing on here with the ICF model, some of Greg's environmental factors are that he has a supportive family, which is good. He lives with his family and 2 young children, which is good and can be bad. Lives in a second-story apartment with 12 steps to enter, which might be a bad thing. He has good access to health care, which is good. He has a big work pitch coming up, which is going to be a negative factor. Some personal factors is that he has anxiety, depression, and stress, which are all negative. And his positives are that he is motivated to be able to care for his family and that he's very compliant with therapy. So here we have some factors that delay wound healing: infection, depression, anxiety, cancer, smoking, decreased sleep, diabetes, poor nutrition, stress, obesity, and alcohol. Some questions to keep in mind when working with these patients is that you want to ask yourself, is the wound deeper than we originally suspected, or is there a skin graft needed?
For physical therapy interventions, we want to include patient education and the effects of stress that the patient may have. Some studies have shown that caregivers reported significantly more stress on the perceived stress scale than controls did. Stress typically leads to lifestyle changes, such as poor diet, sleep disturbances, decreased exercise, and has been proven to delay wound healing. Another intervention we will include will be massage. as well as silicone gel sheets and hydrocolloids. The silicone gel sheets limits contraction of scars through hydration, occlusion, and low molecular weight silicone, whereas the hydrocolloids protects the skin against cracking. We're also going to provide these patients with pressure garments that should be worn 23 hours every day. We're also going to work on range of motion, specifically when the bandages are on and off, but more so when they're off, working on aggressive range of motion to really break up that scar band. We are also going to use modalities on these patients. Studies have shown that matrix rhythm therapy helps restore sensation. Laser therapy is better than ultrasound for pain reduction. Ultrasound low pulse dose helps progress the inflammatory process more rapidly. And these modalities stated above, there's no difference for skin elasticity. We are going to work on aerobic activity, working at 6% of the patient's heart rate reserve. A study showed that activities like the treadmill can be beneficial to burn patients to improve their general deconditioning. Also, aerobic activity has been shown to decrease stress and anxiety as well as enhance feelings of well-being. This is also salient for a patient as he is training for a half marathon. We're going to work on strengthening immediately as well as restoring their ADLs.
So Greg's plan of care should focus on one, patient education. Make sure he understands the wound healing process, why physical therapy is important, and how he can benefit from PT, as well as possible realistic outcomes he may face in the future. In addition to addressing the psychological aspects of his patient care, it's also critical to continue addressing the physical impairments as well. In particular, Greg would benefit from maintaining muscle strength and cardiovascular endurance, preservation of normal range of motion to promote functional mobility and independence, as well as scar and tissue management to prevent contracture. It's also important to consider all options for pain management, considering the amount of pain that Greg is experiencing. A possible option would be diaphragmatic breathing, as well as working with a physician to find relevant and appropriate medications for him. But above all, talk to your patient. Find out, what their goals are and possible concerns might be. In Greg's care, it would be critical to know when to refer out, and as well as recommendations for support systems that he might benefit from. So the clinical bottom line, stress can in fact impair wound healing. Make sure to be aware and look out for signs in your patients, any signs and symptoms such as depression, social withdrawal, increased stress and anxiety, and possible avoidance of things that they used to love. Any kind of burn is a traumatic event, therefore psychological distress is more common than you might expect. According to the research, it's actually the most frequent and debilitating complication post-burn injury. In fact, approximately 1/3 of patients show signs of distress at discharge, and it can lead to a greater physical impairment for as long as 1 year post-burn. So this shows how physical therapy and building a rapport with your patient is a critical part of their care. Once again, educate your patient. They do have control of their healing, and with physical therapy, you can increase function and wound healing through movement. You also want to make sure that you're looking out for patient goals, but most importantly, know when to refer out so that your patient can get the best care possible.